Hello everyone, my name is John Paoli from the University of Gothenburg in Sweden, and together with my colleague Sam Polesie, who will be joining you in a while, we're going to present our results on Interobserver and Human-AI concordance in differentiating between invasive and in situ melanoma. Neither Sam nor I have any conflicts of interest to declare. So, as you can see in this image, we have 4 melanocytic lesions, which are quite atypical in terms of the dermoscopic findings, and they are all flat. They are all brown or black in color, maybe some regression in some cases, but these are melanoma in situ, and perhaps you might have guessed this from the clinical and dermoscopic appearance. Meanwhile, we have these lesions which are slightly raised. Some of them have blue colors, polymorphous vessels, shiny white structures, and multiple colors. So these are probably invasive melanomas. And if you guessed this, you would have guessed correctly. So why is predicting if a melanoma is in situ or invasive important? Well, it's important for several reasons. First of all, of course, we want to try to find melanoma at an early stage, as early as possible. So early diagnosis is, of course, very relevant. We can also give preoperative prognostic information to our patients. So if we know that the patient only has a melanoma in situ beforehand, then we don't have to have them worried for maybe weeks or even perhaps months before they have had their surgery done and the histopathology report in hand. Of course, it's also important for triage purposes and planning dates for surgery. How much of a hurry is it? And lastly, and this is something that we, of course, might have to prove in the future, but this is our firm opinion and hypothesis, that we can choose the most adequate surgical margin based on whether or not we think this is a melanoma in situ or an invasive melanoma. And I'll get back to this topic towards the end of my half of this lecture. So how can we predict if a melanoma is in situ or invasive? Well, we can, of course, approach it in a clinical manner. If it's a flat lesion, then it's most likely going to be in situ or very thin. If it's a raised lesion, like this one, then it's probably going to be an invasive melanoma. And of course, the more raised, the thicker the melanoma is probably going to be. So this is a very simple reasoning, of course. Melanin colors that we see in dermoscopy also give us clues. If we only have browns and blacks, then of course the melanin is probably located in the epidermis. Whereas if we see grays and blues, then we have melanin deeper down in the dermis, and therefore a higher probability of invasiveness, especially the bluer it gets. Now we also have additional colors in dermoscopy in the dermal structures, giving us reds, pinks, and whites if it's fibrosis or different vessels. Then, of course, the more of this we see and the more colors we see, the more likely it is going to be a melanoma that is invasive. So the number of colors does influence our prediction. If we only see black and brown in a flat lesion, so 1 to 2 colors, and specifically these 2 colors, then it's most likely going to be in situ. Whereas if we start seeing 3 or more colors, including not only brown or black, but also gray, blue, white, red, and or pink, then it could very well be an invasive melanoma. So to the left, we could probably predict that this flat, brownish colored lesion is going to be a melanoma in situ, whereas to the right, where we have brown, black, but also blue and white, and perhaps even some reddish tones in the background, this is going to be an invasive melanoma. Of course, dermoscopically, we can also get even more specific because we have melanoma-specific criteria, dermoscopic findings that indicate that this is a melanoma, and some of them are shown in this image here. But of course, some of them might predict invasiveness and some might predict that this is an in situ lesion. Now, our studies have shown, and Sam will show you the results more in detail later, that predictors of invasiveness are mainly and the most specific is perhaps atypical blue-white structures. But also shiny white lines and polymorphous vessels may be indicators or predictors of invasiveness. So in this example here, we have a lesion with a globular pattern in general, but also blue-white structures that are atypical in the central part of the lesion and also towards 12 o'clock. So atypical blue-white structures indicates invasiveness. In this lesion, we also have some atypical blue-white structures at 6 o'clock, but we also have polymorphous vessels and shiny white lines. So all of these are indicating a possible invasiveness. Of course, this is also a flat lesion, so it's probably thin invasive. In this example here, we have a clearly raised lesion with multiple colors, blue, white, red, and of course, polymorphous vessels. So atypical blue-white structures, polymorphous vessels, raised lesion, all of these predict, of course, an invasive melanoma. Now, do we have any predictors of melanoma in situ? Well, if it's a flat lesion, if there's mainly brown or black colors, well, then you can almost guess which ones are going to be the most valuable in predicting if it's a melanoma in situ. We have an atypical network, irregular hyperpigmented areas, angulated lines in the lentigo maligna type of melanomas, prominent skin markings when it's actually indicating that it's a melanoma, and extensive regression. All of these features are common in flat lesions that are early invasive or mainly in situ melanomas. So in this lesion where we only have brown colors, different shades of course, and a slightly atypical network in terms of the distribution and color, perhaps the thickness of the lines, a melanoma in situ. Another lesion that's flat, only two colors, brown and black, with irregular hyperpigmented areas, again, a melanoma in situ. One more flat lesion, again, only brown colors, brown tones, and we have angulated lines. Of course, this is an extrafacial lentigo maligna, so melanoma in situ. And this atypical lesion that happens to have prominent skin markings, of course, not super specific for melanoma, but in this case, a suspicious lesion indeed. But if we're going to suspect that this is a melanoma, we want to guess melanoma in situ, and this was in fact the case. And here we have another flat lesion on chronically sun-damaged skin with widespread regression covering at least 50% of the lesion, also indicating melanoma in situ. And lastly, I wanted to talk a little bit about the wide margin approach and what predictions of whether or not a melanoma is in situ or invasive can actually do to change this approach in the future. And what Sam and I propose and what we have been discussing in our publications and also in different presentations is that why are we still doing the following, where we have a lesion such as this one, where we can clearly see that this is not an invasive melanoma, but it is an atypical melanocytic lesion in which we may suspect a melanoma in situ in the worst case scenario. Still, we do a diagnostic excision with a 2 millimeter margin. We confirm that it was a melanoma in situ, and then we have to do a wide excision of the scar with a 5 millimeter margin. So instead, what we propose is a WISE margin approach. And the WISE margin approach is excising the suspicious lesion immediately with a 5 millimeter margin because we already can predict that this was an in situ lesion in the worst case scenario. This will save healthcare and the patient a lot of unnecessary costs, pain, suffering, and excessive work. Of course, this requires dermoscopic knowledge, it requires experience, it requires confidence in our predictions, but we do think that this is the future of melanoma healthcare. So with this, I'll say thank you from myself and for listening to my half of this lecture, and enjoy Sam's second half. Thank you very much. Bye-bye.
Hello everyone, my name is Sam Polesie and I'm a dermatologist working in Gothenburg. For the next 10 minutes or so, I will briefly discuss our most recent research data relating to invasive versus in situ melanoma and how capable dermatologists are in this binary classification problem, and also how we can deploy convolutional neural networks to help us in this task. For this talk, I don't have any relevant conflicts of interest. Okay, so in the next slide, you will see an image that will only be available for a fraction of a second. I think we all can agree that this was a melanoma, but was it invasive or was it in situ? In fact, this is a very frequent classification problem often faced by everyday clinical dermatologists, particularly in the pre-operative setting. So invasive or in situ, that is the question. But why is this issue really important? We know that suspicious lesion should be excised anyways. Well, it might have consequences for decision margins for the first primary excision, and it might also be important for the priority and triaging purposes for surgery, which is often limited. And finally, it's also nice to give the patient some kind of heads up on what's your primary suspicion for a specific lesion. So at our department, we deploy a 2 millimeter excision margin for lesions that we have a high suspicion of invasive melanoma. However, if the primary suspicion is in situ melanoma, we use a 5 millimeter excision margin. These are the publications I will discuss with you during the remainder of my talk. The first publication was published in Dermatology Practical and Conceptual, and for those of you that are particularly interested in this topic, please find the QR code on the right-hand side. Using this link directs you instantly to the online version of the manuscript. In this investigation, we included 184 lesions, that is 110 invasive and 74 in situ melanomas. We invited 7 dermatologists to assess this data set, and they independently were required to answer whether they believed the lesion was invasive or in situ melanoma. To avoid any recall bias by the observers, we only included melanomas that were excised more than 3 years prior to study initiation. Most invasive melanomas were thin, and only 32 lesions had a vesicle thickness of more than 1.0 millimeter. All dermoscopic images evaluated in this investigation can be found using the QR link below. The overall diagnostic accuracy in differentiating between invasive and in situ melanoma ranged from 67.4 to 76.1% among the 7 dermatologists. The accuracy for correctly classifying in situ melanomas ranged from 53.1 to 61.8%, whereas the overall diagnostic accuracy for classifying invasive melanomas were higher. Interestingly, all invasive melanomas with a breast thickness of more than 1.0 millimeter were correctly classified by all dermatologists as invasive melanomas. The Interobserver agreement in classifying lesions as invasive or in situ among the 7 dermatologists was moderate, with a kappa value of 0.47. Some lesions were more challenging than others. This is an example of 4 dermoscopic images of lesions that were classified as in situ melanoma by all observers, but they were in fact all invasive. Luckily, all these lesions were invasive melanomas with a breast thickness below 0.5 millimeter. The sensitivity for predicting invasiveness ranged from 64 to 92% for the 7 observers, while the specificity for this classification was 32 to 82%. In another publication published in Acta Dermatovenerologica, we addressed the specific dermoscopic features that were indicative of invasive and in situ melanoma respectively. And for the included features, we also analyzed the Interobserver agreement. In this investigation, we included 182 lesions, consisting of 81 invasive and 101 in situ melanomas. And the same 7 dermatologists were invited for this investigation as well. Most of the included melanomas were thin, and only 22 had a breast leaf thickness of more than 1 millimeter. These were the pre-specified dermoscopic features that needed to be specified for each and every one of the included lesion. All these findings are a derivative of the revised two-steps algorithm, which is an extension of the pattern analysis. As you can appreciate in this slide, atypical blue-white structures and shiny white lines were particularly prevalent among the invasive lesions. And in terms of interobserver agreement for these specific features, atypical blue-white structures and shiny white lines both had a substantial interobserver agreement. As you can see here, the highest interobserver agreement was observed for negative network. However, negative network was not indicative of invasive nor in situ melanoma in this investigation. As you can see in this figure, atypical blue-white structures was in fact the only dermoscopic feature that was useful in terms of differentiating between in situ and invasive melanoma with a high odds ratio. No features per se were indicative of in situ melanoma. However, when the in situ melanomas and the thin invasive melanomas, that is melanomas with a breast leaf thickness below 1.0 millimeter, were merged to one group, atypical blue-white structures and shiny white lines were both indicative of invasive melanomas with a breast leaf thickness of more than 1.0 millimeter, whereas regression and peppering was indicative of thinner lesions. We have also addressed the capability of convolutional neural networks in this setting in terms of differentiating between in situ and invasive melanomas. This publication was published previously this year in the JAD. For this investigation, we included 1,137 histopathologically verified melanomas, consisting of both invasive and in situ melanomas, and randomized these images into a training, a validation, and test set. We constructed a de novo convolutional neural network with the aim to classify lesions as either in situ or invasive. The final model that we deployed was evaluated on an external test set, which was also assessed by 7 independent dermatologists. In that way, we could investigate the performance of the CNN compared to the dermatologists. The dots represented here are the invited dermatologist scores in terms of sensitivity and specificity for classifying invasive melanomas. And as you can see here, the receiver operating characteristics curve for the CNN was slightly lower than that of the dermatologists. And you can see the combined dermatologists ROC here. However, in terms of the area under the receiver operating characteristics curve, the CNN was not outperformed by the dermatologists. The final investigation was published in Frontiers in Medicine. This study only included clinical close-up images of melanomas. Overall, 1,551 histopathologically verified melanomas were included in investigation, and this dataset was randomized into a training, a validation, and a test set. The test set was again evaluated by 7 dermatologists, and each dot here represents one dermatologist, and as in the previous investigation, this is the ROC for the CNN, and this is the combined ROC for the dermatologists. In this study, the AUC for the dermatologists was higher compared to the CNN. So now we have data on a CNN that was trained and validated on dermoscopy images and a CNN that was trained and validated on clinical close-up images. And the next step is, of course, to create a merged model where we integrate both the dermoscopy and clinical close-up image. We have also 1,500 melanoma dermoscopy images that, of course, we will share in future investigations. And we have also initiated collaboration with the Medical University of Vienna and the University of Heidelberg. And we hope that you can read more about this collaboration in subsequent manuscripts. And with that, I would like to conclude my talk, and I hope that you will join us in the live discussion session 3 at the Augmented Intelligence in Practice on the Thursday the 9th. Thank you so much for listening. Bye-bye.